bear with me while I get my screen share set up. Okay, so I've had the pleasure of knowing or working with several of you in different capacities, and I'm excited today to actually tell you about the work that I'm really passionate about, which is pediatric sepsis. And if we have time, we'll get to my research at the end, but that's actually not the main thrust of this talk. It's really more about the background of it and how we got to where we are and how that inspired the research that I'm doing. So if we get there, great. If not, that's also okay. And then because we do have trainees, I want to go through my story. I think it's helpful. You've heard many different career paths at this point, and it's just nice to hear how everyone's found their way differently. So then we'll talk about specifically the barriers, challenges, and controversies associated with pediatric sepsis in resource-limited settings. And then, like I said, if we have time, we'll get to my work. And then I do have some different ways for people to get involved if you're interested in learning more, and we'll get to that regardless. So in terms of my story, I really got hooked on global health as an undergraduate. I studied abroad in South America, and it was there that my eyes were really open to the health disparities that exist. And it just seemed incredibly unfair that where a child was born determined their access to education, health, clean water. And that launched me on my passion for global health. And so anytime there was an opportunity, I looked toward and I took it. So global health track at medical school, any type of rotations abroad. Throughout residency, I had an opportunity to rotate with the Baylor AIDS Corps, which was a phenomenal experience. And then it was one of the Yale-Stanford Global Health Scholars, which I had the opportunity to work in South Africa in an HIV and TB clinic in rural South Africa for a couple of months, which was also really impactful. And then it was in fellowship, in a critical care fellowship, where I wanted to do a research project, and I went to Bangladesh and I studied. They had just implemented sepsis guidelines for pediatric patients, and it was based on the Surviving Sepsis Campaign guidelines, so evidence-based. And they had never actually looked at outcomes before and after, but the hypothesis was that the protocol would actually improve clinical outcomes. And so we looked at it to actually show that, and we were completely surprised that not only did clinical outcomes not improve, but there were some indications that they were getting worse. And that's what launched me on my clinical research endeavors, because that just opened up an entire Pandora's box. So here we have evidence that's not working. Why? And it was due to resource availability and training, and also because of the differences in the patient population. And that really just set me off in terms of my research endeavors. And so I decided to get a master's degree in global health sciences at UCSF after finishing fellowship, and loved it so much that I decided to stay on, and I'm currently getting a PhD in global health sciences in the clinical research track. They really wanted to have the epidemiology and biostatistics to be able to do really important clinical research work. I'm also attending at UCSF in the pediatric ICU here in Mission Bay, and recently took a little bit of a hiatus to be the sepsis consultant at the WHO. Happened to be there literally the day that they declared a global pandemic. And so while I was there to help develop sepsis guidelines and write the first global epidemiologic report on sepsis, I quickly got shifted off of sepsis and onto COVID pandemic response work. And one of the reasons was because they just don't actually have that many clinicians at WHO, and I'm one who has critical care background. So quickly started doing a lot of training and educational resources for providers in resource variable settings, trying to get them rapidly prepared to take care of ventilated patients with ARDS. I was glad when the consultancy ended, quite honestly, because it was very intensive, and I could tell you more about it over a glass of wine someday. But the plan was always for it to end and then to come back to UCSF, because shortly thereafter my K-23 started, and that's what I'm doing right now, and that's focused on studying pediatric severe febrile illness, primarily etiology and biomarkers in East Africa. So it sounds, when I say it, like it's somewhat of a logical progression, and it had like this direct path, but I will tell you it's not at all, and it's really more like this. A maze that may or may not be filled with water or quicksand, who knows? And so it's definitely like a winding path throughout. And I think you've heard this from other speakers as well, like where you are is where you need to be, and different opportunities will present themselves at different times. And just being open to those possibilities has really made the big difference. Okay, ready? Time to wake up and see if we can use those annotation features. So at the top of your screen, there should be a little toolbar. If you click on that, you should have an option to annotate. And so we're going to do this as a poll, but kind of as in a low tech fashion. So with the annotate function, I think you can do an emoji or you can use the text feature. And I would like you to vote. There you go, Cheryl's got it. Vote next to your favorite type of chocolate, dark milk, white, and what is chocolate? Oh, all right. We're seeing lots of love for dark. I love it. It's so funny. Every time I do this, dark chocolate always wins, like hands down. It's amazing. So I'm definitely a milk chocolate fan. And fun fact, so while we lived in Switzerland for this WHO consultancy, granted it was a pandemic and we were on lockdown, so maybe that contributed, but I ate about 2 kilos of chocolate a month, which actually puts me above the average Swiss person. They eat about 9 kilos a year. So I was well on my way to becoming Swiss. So great. So now we know how that works. And I'm going to ask you to do that a few other times throughout. And let me just clear it. Clear all. Beautiful. Good. It works. Wonderful. All right. So now to kind of the meat of this, and that's how did we get to where we are? And so we have to start by talking about the burden and then what are the current definitions and guidelines so we have a good understanding. So we'll start by talking about sepsis by the numbers. And there was a landmark paper that was published in 2020 by the Global Burden of Disease group out of Seattle. And it estimated the global burden of sepsis. Thanks, Kelly. What they found, or what they reported, were actually numbers that were significantly higher than previous observational studies had shown. So they estimated that in 2017, there were about 49 million cases overall, adults and children, but 20 million of those cases were in children under 5. So that means that 2 out of every 5 cases were occurring in young children, so our patient population of interest. And then there were 11 million deaths associated with sepsis. So that means, and this is an astounding number when you think of it, so 20% of all-cause global mortality was associated with sepsis, and about 3 million of those deaths were happening in the youngest age group, less than 5 years. So those numbers were staggering and so much larger than anything that we had ever really observed or reported previously. And the other thing that was really interesting from this report was that both cases and deaths, 85% were occurring in low and middle income countries. And I think that that's better illustrated by this map. It's a bit of a heat map. And what you can see is this is showing you proportion of deaths related to sepsis, where the darker the color, the higher the proportion. And just in a split second, you can see the disparities that exist between high-income countries and low-income countries. And I'll tell you that a map of sepsis incidence actually looks really similar to this. So then that leads me to ask myself, like, so, okay, so they're dying from sepsis, but what causes of sepsis in children, and specifically in less than 5 age group? And so I started by just looking at the causes of death in children under 5. And Sabrina, I'm going to put you on the spot. Can you tell me a few of the things that you're seeing or common themes you're seeing in this list? Are you able to come off mute, Sabrina? Maybe not. All right, Medron. See if I know your name, then I can call on you.
Yeah, so it looks like the highest one is lower respiratory infections, diarrheal illness, malaria, and meningitis.
Yeah, exactly. So you're seeing a lot of infection and a lot of preventable infections, right? And all of those can cause sepsis. So that we've used that term sepsis now a few times, but I think that this is something where there's different definitions for sure in the literature, and that we use it differently clinically as well as in a research context. So I wanted to stop here. It's time to vote again. What sorry, you can probably see everything. You get to vote for one or more of the following things. Which of these words should be included in a definition of sepsis? Clinical syndrome, inflammation, infection. Oh, I like the variation in emojis. That's good. Oh gosh, yeah. Okay, so wow, eyeballing it, it looks like we've got lots for inflammation, infection, and organ dysfunction, as well as clinical syndrome, but we have all of them represented to some extent. Great. I would completely agree with you. And I actually, the definition that I like the best is this one, the sepsis 3 by Singer. And this is the current adult definition for sepsis. So life-threatening organ dysfunction caused by a dysregulated host response to infection. And what I like about this is that it's really highlighting that complex interaction that happens between the pathogen and the host inflammatory response. So it's not enough to just have an infection, it's the host response as well. And then the other important piece of this is that any pathogen can cause sepsis. So it could be a parasite, it could be a fungus, it could be a virus. It doesn't have to be bacterial at all. And I think we're having more awareness of this, especially in the COVID pandemic, that viral syndromes can also cause sepsis. So sepsis has obviously been a concept that's been around and has been life-threatening since it, was identified as a clinical syndrome. And in the early 2000s, there was this international effort to really increase awareness and improve outcomes. And a bunch of experts got together around the world and developed management guidelines based on early goal-directed therapy. And if any of you know any of the names on this list, they're kind of like the original people who published the first studies in sepsis and physiology and resuscitation. This group later became known as the Surviving Sepsis Campaign, and they're kind of the go-to body for guidelines. And really, they had some pediatric relevant guidelines in their guidelines and their revisions, because they revise them every 4 years, but there haven't been pediatric specific sepsis guidelines until just last year, where they actually did the first dedicated Surviving Sepsis pediatric sepsis guidelines, which is great. Overall, though, I will say that my takeaways from this are that there's a lack of primary evidence in pediatric sepsis, and that it was also obvious that we need guidelines for resource variable settings, and that many of the recommendations were actually intended for high-income countries. So what about bodies that create guidelines for low-income settings and resource variable settings? So I looked at the WHO, and this was actually one of the reasons why I was brought on as a consultant, is because the WHO does not have dedicated sepsis guidelines for adults or children, which I actually didn't realize because I thought for sure they would. But the closest thing that they currently have is the Pediatric Emergency Triage and Assessment and Treatment Guidelines. And for those who are going to do rotations abroad, this is a good resource to be aware of. And Annika referred to this yesterday too, in terms of the emergency signs to be aware of and kind of the initial management. So it was originally published in 2005 and then updated in 2016. And the guidelines focus on kind of the care of critically ill children, and then this like identification of the priority signs that are really red flags. And then of course we have the PALS guidelines. So don't forget that there is a pediatric septic shock algorithm in your PALS card in terms of guidelines that are evidence-based. Okay. So that's the background, but what about sepsis specifically in resource-constrained settings? What are the particular barriers and challenges there? So before the Global Burden of Disease study, one of the largest studies that we had in pediatrics was this, we call it the SPROUT study, but the Global Epidemiology on Pediatric Severe Sepsis. And this was a point prevalence study that estimated the prevalence of severe sepsis in children in pediatric ICUs around the world. And they had 126 centers, which is a good representation, or a large number. And they estimated 8% global prevalence of severe sepsis with a 25% in hospital mortality rate, which is a really high rate. Like, try to think about another pediatric illness that actually has a 1 in 4 likelihood of death. Interestingly, though, they found that there was no significant difference in outcomes between the high and low income countries, which I found really surprising, because based on everything that I know and have experienced, I didn't expect that. But the only sub-Saharan African country included was South Africa. And again, these were children who were admitted to a PICU. So if no PICU exists, the children were not couldn't be included in this study. So, one of the reasons I was surprised is because I work primarily in Tanzania, and, based on my knowledge of the population in the country, about 20% of the population lives in poverty. There's limited access to clean water and sanitation, very limited healthcare workforce. They have 0.1 physician per 10,000 physicians, whereas the US has about 25. So it's just like orders of magnitude different. 5 out of 100 children will die before the age of 7, and that's more than 7 times what it is in the US. They have a high number of under 5 deaths. And then thanks to the Global Burden of Disease study, we actually know that about 1/3 of all deaths in Tanzania are associated with or related to sepsis. And this picture is actually from Malawi, but I think is representative of many of the pediatric wards in sub-Saharan Africa. And so I'll open this up for the group to just please come off mute. What are some of the challenges and barriers that you can think of for managing pediatric sepsis in a setting like this?
This is Jean.
Go ahead, Jean.
Oh, I was going to say there's infection control and prevention is extraordinarily difficult, at least in settings where I've worked. Even getting fluids to drip at the right rate is very difficult. Lack of resources for oxygen, no ventilators, lack of monitoring, lack of staffing to monitor.
Yeah, Kelly put in the chat, equipment availability, that's true. And I would say with resources, we need to think about it not only in the equipment, but also the medications. And think about resources in terms of personnel too, like people and clinicians who have adequate training and adequate numbers are also a resource that is often constrained. So yeah, monitoring is another one that I think isn't thought of often. An inconsistent supply chain, this has come up in several of the talks, including the island medicine. So, if things are available, that's great. If they're not, there isn't a backup. Yeah, I think isolation precautions, so infection spread and IPC measurements or IPC measures. Nursing is a huge one, right? Just not having enough nurses for the volume of patients, which limits your availability to do repeat assessments, normal or regularly scheduled vital signs. Yeah, there's no space, Becca, you're absolutely right. They're literally on top of each other. They might be sharing an oxygen concentrator and splitting the tubing. Difficult to diagnose, especially if there's limited diagnostic capacity. Yeah, simple monitoring, Kalab says, like pulse ox, and then it's not enough to just put on a pulse ox. You need someone who can actually respond when the alarm is going off and know what to do if the oxygen saturation is low. And delay in accessing care to begin with is absolutely true, Kelly. Like now we're getting into health systems and infrastructure. So yeah, great. I agree with everything that you said. The one additional thing that I would add is that I think that the patient population is also unique. So when we talk about sepsis being this interplay between the host and the pathogen, I think that's population and context specific. So what are the common pathogens? So maybe it's dengue or chikungunya or malaria. And then what about what's different or unique about this population versus another population? What are the underlying rates of malnutrition, HIV, tuberculosis? Because all of those are going to change that interaction. So agree completely with everything you guys added. So when I distill this down into what I think the biggest challenges are, it's how do we identify sepsis rapidly and accurately? And then once we identify it, many of these children are coming into community health clinics or district hospitals. How do we actually refer them to a place that can do definitive management or care? And then we need to have the resources available to treat sepsis. So maybe you identify it, but if you don't have what you need to treat it, it's irrelevant. And then finally, what is the best treatment for sepsis? So let's break that down a little bit. So this is the current definition. It's super overwhelming with tons of words on the page, but this is the current definition for pediatric sepsis. And what the important thing is to know is, one, it's very old and it hasn't been updated, unlike the adult definition, which has been updated multiple times since the early 2000s. And it's all based on the presence of the systemic inflammatory response syndrome, which is usually classified by these criteria, which involve abnormal vital signs for age. So it's the presence of this inflammatory response in the setting of an infection, either suspected or proven. And then based on the degree of organ dysfunction, you go up the spectrum from sepsis to severe sepsis to septic shock. So this is the current definition that we are operating with. There's a lot of criticism with this definition. I'll be perfectly honest with you. And this is one study out of Uganda that enrolled over 1,000 pediatric patients in that under 5 age group. They were admitted to the ward. They had a confirmed or suspected infection, so they had a fever. And then they used this third definition for sepsis, and it calculated the prevalence of sepsis. And there's a relatively low mortality in this cohort of 5%. So they looked at the individual characteristics for SIRS and sepsis, and then using the full definition of sepsis, what they found was that the overall sensitivity, so 86% actually met SIRS criteria. And so the sensitivity was 95%, but the specificity was really poor. It was only 15%. And the positive predictive value was 5%. Those are a bunch of numbers. What those actually mean clinically is that we have this incredibly sensitive definition. So basically everyone falls in the sepsis bucket, but when we're actually trying to predict who's going to die, so who's at highest risk for mortality, so when we get into the specificity, we're very poor at predicting the kids who have a bad outcome, who have death. And so that just shows us that everyone kind of falls in the sepsis bucket, but that's actually kind of a meaningless bucket because it doesn't tell us what their outcome is going to be. So then the next issue I kind of wanted to tackle and look at the research that's been done is, what about referral and transfer? So we talked about being able to identify the patient and then getting them to definitive care. And this study is out of South Africa, and they basically followed critically ill children from the time of presentation all the way to either their PICU admission or if they died in the emergency department. And they reviewed their records and tried to determine overall quality of care and if anything was avoidable in terms of serious illness, admission, or death, and then looked at what those modifiable risk factors could be. So again, a lot of words on this page, but what you see here is that they have it broken down by the health center where they first presented to. And the thing to focus on is the major modifiable factors category, or the column. And what you can see is that this time after time in each of the different settings, you'll see some recurring themes. And so overall, the key modifiable risk factors that are very common was related to access to care in the first place, and then identifying the kids who are sick, adequately fluid resuscitating them, being able to assess the severity of illness, and then delays in decision making, which then also led to delays in referral. So you can see it's like a multi-step process that is leading to the delays in care. They also found in this study that there was potentially avoidable severity of illness in about 75% of the children, and they thought that almost half of the deaths could have been avoided if something along this kind of care chain had been improved, which is kind of shocking, especially considering that South Africa has probably the best healthcare system and infrastructure, and Sub-Saharan Africa are one of the better ones. So I think the next potential barrier that we identified is really about the resources available to treat sepsis. So we can have all the guidelines in the world, but if we can't implement them, then they're no good. So this was an anonymous survey. It was sent to anesthesia providers primarily in Africa, and then the high-income countries were mostly in Europe. And it just looked at, do you have the materials available to implement the guidelines? Not even are they implemented, or have you used them, or have they changed outcomes? Can you even do them? And I just want to draw your attention to, there's two tables. So the top one is comparing African countries to the high-income countries that were, again, mostly in Europe. And then the bottom one is just comparing within Africa. And so that shows you like two levels of disparities between high income and low income countries, and even within the continent of Africa, there's pretty significant disparities. And the number I think to focus in on is that in African countries overall, and sub-Saharan African countries, less than 2% had everything that they needed to implement the guidelines. So that's the first barrier. Like we can't even get to implementation or feasibility or durability if we don't have the tools to be able to do it. So that made me look a little bit more critically at the current pediatric guidelines for surviving sepsis. And these are a couple of the excerpts that I kind of pulled out. And I'm going to ask you to look at them and see what are some of the things that you might actually see as barriers to implementation of these guidelines in limited resource settings. You can either put it in the chat, come off mute, or if you're really into the annotation, yep. Blood lactate, we've got a no advanced monitoring. Yep, that's one. Trending a lactate, right. Renal replacement therapy, right. We take that for granted, I think, oftentimes here. Inhaled nitric oxide, that's not easy. ECMO, ability to get blood cultures, right. Let's forget ECMO, like can we even get a blood culture in a timely manner? Making a diagnosis, absolutely, yeah. What about non-invasive and invasive mechanical ventilation or daily assessments, being able to make a diagnostic, being able to do an intervention for source control? That implies having the tools and the expertise available to do something like if a surgical procedure is needed, or even a bedside procedure for draining a pocket of fluid. Yeah, so I agree. I identified the same things that you did. Appropriate antibiotics. Yeah, antimicrobial resistance is a huge problem, which actually isn't even reflected here. So definitely all of those things. So I think it's a great first step, but definitely it needs to be modified for resource variable settings. So I mentioned the original ETAC guidelines, and this was from the 2005 WHO ETAC guidelines, and it actually reflects what were the PAL guidelines similarly at the time. And so you can see it's back to back to back, 20 mLs per kilo, 20 mLs per kilo, just keep pushing fluid. But there's definitely a controversy around fluid, and it's not even a new controversy anymore, but I will say that it is a persisting one. And that's because we have conflicting data, and it's really dependent on the population that's being studied. So a lot of the earliest work in fluid resuscitation came out of US pediatric populations and European populations. And it showed that aggressive fluid resuscitation by community providers prior to referral actually decreased mortality. And when I say aggressive, it's 40 mLs per kilo within an hour of presentation. And this study, it was Hahn et al., actually found that with inadequate fluid resuscitation, that was associated with the highest risk of death. So here's a study that is strongly in support of rapid, large volume fluid resuscitation. But in other settings, though, you get kind of these mixed results. So in Brazil, they also found that high volume fluid resuscitation within an hour decreased the odds of mortality. In Colombia, another group kind of randomized, or not randomized, looked at groups that had a group of children that had received early rapid fluid resuscitation and found that they had less respiratory failure. In contrast to that, in India, they found that children who received rapid fluid resuscitation were more likely to have respiratory failure and require intubation compared to kind of a slower resuscitation over a longer period of time. And it's not that much longer. It's the difference between like 5 and 20 minutes. And then we have the big daddy. So this is really the study that is the most controversial and has led to the most debate in the field. And that's because it is a large multi-centered randomized control trial. It's conducted in African children with shock, and they have over 3,000 children. And for those who do studies, you can appreciate that this is a large sample size for a pediatric study. And it's actually the only randomized control trial that we have for fluids currently, although there are a few underway, both in the US and Canada. And so the children in this study were randomized to basically 3 arms. They either got a normal saline bolus, an albumin bolus, or no bolus. And the initial intent of the study was actually to do a comparison between normal saline and albumin, because we're always debating like which one is the better fluid to resuscitate. And then as like an afterthought, they throw on this like 3rd arm of no bolus. And they were completely astounded by the results, which were somewhat as expected, earlier reversal of shock with bolus resuscitation, but also increased mortality. So the relative risk of death with any bolus, and it didn't matter if it was normal saline or albumin, was 1.45 compared to control. And they saw this excess mortality across all subgroups. For the residents on the call, are you familiar with this study? Have you heard about this before? No? It's over a decade old now, so it's becoming, I guess, maybe less well known. But I can tell you at the time it made a really big splash, and we were all, this goes against our classic teaching and the way that we manage shock here. So we were all kind of scratching our heads and trying to figure out what the underlying pathophysiology might be. There were definitely a few hypotheses that kind of rose to the surface as to why rapid fluid resuscitation would actually lead to increased mortality. One thought was that there could be a reperfusion injury-like phenomenon. So similar to after you have a transplant and then you reestablish blood flow and you do it really quickly, you can cause some endothelial injury and inflammation. So is it possible that the bolus fluid is doing something similar? Another hypothesis was that there was myocardial dysfunction secondary to a worsening acidosis or potentially fluid overload. And then the concern for capillary leak or third spacing in a population that has chronic anemia, chronic malnutrition, especially protein wasting, and then malaria positive patients, specifically P. falciparum, can cause capillary leak. And then is it just that we're causing fluid overload? And that could manifest clinically as increased intracranial pressure, respiratory failure, or myocardial dysfunction if you're kind of pushing them over their Starling curve into heart failure. And all of these, the thought is that any of these could actually be very harmful in settings where there aren't ICU resources available to kind of rescue the patient. So maybe these phenomenons are happening in our patient population as well, but because we have renal replacement therapy, because we can intubate, because we can start a Lasix strip, we actually don't see the downside, the downstream effects of this. And then Kalab adds as well, a really good point that myocardial dysfunction is more pronounced in sepsis. So it's maybe like this two-hit phenomenon. And I will also say that with malnutrition as well, there are studies that have shown that myocardial muscle mass with chronic malnutrition decreases. They have looked at, though, cardiac function and fluid resuscitation, specifically in malnourished populations, and did not see decreased function or kind of passing over the Starling curve into heart failure in active fluid resuscitation. But that's another thing that we've worried about is like that stacking of comorbidities. So malnutrition and fluid overload and sepsis, and all of that kind of pushing someone over the edge. So I guess fortunately, the FEAST trial group did a post hoc analysis of the data that they had, and they actually looked at the terminal event. So what is kind of the, it's not the cause of death, more like the mode of death for the patients in their randomized controlled trial. And they basically, they didn't have autopsy results. So this is all based on medical records. And they had 3 independent reviewers who read the events as well as the death note and tried to determine if the child died from a cardiogenic terminal event. So that's basically cardiovascular collapse or shock. If it was a neurologic event, and that's basically increased intracranial pressure, or respiratory failure, also related most likely to fluid overload. And then some, they just weren't able to classify it at all. And so I think that the thing that I pulled away, that I took out of this, if you look at the red line, so the top line, I don't know if you can see my mouse, but the top line that is so much higher than all the rest is cardiogenic or cardiovascular collapse in children who received a bolus compared to the children who didn't receive a bolus. So this is just fascinating to me that the children who receive bolus resuscitation have earlier reversal of shock, but then still die of shock in kind of that like 2 to 12 hour period later. So I just think that that's just really interesting physiology. And that's one of the things I hope to look at more is the reasons behind that. And it's also something that I don't think that I've really observed in a high income setting. So I'm very fascinated by that. If anyone else has any thoughts or hypotheses, I would love to hear them. So now I'm going to ask you to really kind of digest this and see, based on all of the different data that are available and what I've showed you, would you change how you would approach fluid resuscitation in a child with shock? So you get to vote.
In what setting, Teresa?
Oh, good question. How would it be different for you? Is that you, Asya?
Yeah, no, I wasn't going to answer yes, but I mean, I think for me, it would be different.
Okay. And how would it be different if you're at St. Jude versus, you're in Uganda?
Yeah, so I think if I had access to critical care resources, I would approach it with the standard, high resource approach. But if I didn't, I think this would make me want to practice with a much more conservative strategy.
Okay, so you're going to put your emoji kind of like in between yes and no.
Yeah, it depends on context.
Yeah, okay, that's fair. I only see 2 other votes, 3, good. Okay, so this is compelling evidence. Yep. So some more kind of in the middle, like yes and no, dependent. Yeah, so I agree with what you said, Asya. I think it is really context dependent. So did it change my practice when I'm practicing in San Francisco? No. And that's because I have the full toolkit available to me to rescue a child if anything goes wrong, if they have fluid overload. I have the maximal amount of resources available. However, does that change how I approach a child that I see in the emergency department in Tanzania? Yes, it does. So I agree entirely. It's context dependent for me personally. And I will say that other groups also adjusted their guidelines. And so remember I said that the initial ETAC guidelines were written in 2005, but then they were revised in 2016. And one of the major revisions was about fluid resuscitation, and it was to take into account the results from the FEAST trial. So now they make this distinction between the children in shock and not in shock. And to be in shock, you have to have 3 signs of impaired circulation. So you have to have delayed capillary refill, cold extremities, and then a weak and fast pulse. And honestly, if a child has one of those in San Francisco, I usually start with a fluid bolus and go from there. But the current ETAC guidelines or the revised ETAC guidelines say do not give this patient rapid infusion, prioritize reassessing them, and then give them fluids via other means, and then reassess often. So it's really only for the kids who are in shock, who have all 3 of those signs, who should get fluid resuscitation. And if you'll notice, the volume is less and the duration is longer. So it's less volume over a longer period of time. And then this reassessment piece is actually really critical. And that's something as well that has been built in to the ETAT and the AHA guidelines as well. We did this a little bit on Carmen's presentation, but what would you be looking for on reassessment? Sonia, I'm gonna put you on the spot. So after your first fluid bolus, what are we specifically assessing for?
Like signs of fluid overload. So like we're listening to the lungs and also looking at the lower extremities.
Mm-hmm. And hepatomegaly, you can look for JVD. So you're looking specifically for right heart failure due to fluid overload, right? And then it looks the same way as it actually does in adults. So that's important, that reassessment piece. So if you give fluid and then you realize that the patient now has crackles that they didn't before, they now have hepatomegaly, you need to stop giving fluid and evaluate their cardiac function. And you can see that the current guidelines actually do involve another 10 ml per kilo bolus, but again, a smaller volume over a longer period. And then if they're no longer in shock, stop bolusing. There are some caveats that are patient population specific. So if they're anemic, you transfuse. Don't do bolus fluids because you'll dilute the oxygen carrying capacity further. And for the patients with severe acute malnutrition, you go even slower over a longer amount of time. And if you can, use an NG tube and enterally give them volume.
I was wondering,
And
wondering about your thought on using blood. You might get to this later in your talk. So I was recently abroad in Liberia, and there was a kid who came in with presumed gastroenteritis and hypovolemic shock from that, with a hemoglobin of 13.6, but the thought was that the child was hemoconcentrated. And the team was actually really interested in trying to move to blood as a sort of like a colloid for him.
Oh, that's interesting. So I'm not going to cover it in this talk, but there's actually more and more literature that's coming out that blood, because we used to move to blood pretty early in sepsis, and it would be like, you do your fluid, you do 3 boluses, and if their hemoglobin, I think initially was like less than 10 or 12 or something like that, we've moved the criteria down. We would move to blood sooner, a lot sooner. And that is actually, the mindset is changing in critical care medicine because of the new data that is emerging, that blood itself might actually be harmful and cause a secondary inflammatory reaction. And that most of our studies are actually with packed red blood cells. But when you're looking at a resource constrained setting, it's often whole blood, which is thought to be even more, it's even more immunogenic. So even more potential for causing an inflammatory response because all of the cell types are in there, including the white blood cells. So now the current WHO recommendations are to transfuse for a hemoglobin less than 5. I would say that if a child is in shock, I would transfuse, at a higher hemoglobin, but still like that 7 cutoff. And the reason being that I have seen the data both from high income countries and actually what the study that we did in Bangladesh showed that there was increased fluid overload and worse clinical outcomes. And the one thing that did increase consistently after the implementation of the guidelines was increased blood transfusions. So I
Interesting.
worry that this is one of those unintended consequences where we're causing more harm than good. And I don't think that blood is always the answer. We used to think it was, but I think there's more evidence now that it's not. So I reserve it for patients who are bleeding and they need the blood or have severe anemia, and then it makes sense to me.
Thanks.
Hey, Teresa.
Yeah.
I have a question about this New England study. In terms of the like timing of the fluid resuscitation, was it like appropriately timed in terms of like it truly was earlier? Like how soon after presentation were these children treated with fluids? Because I guess my thought is if they were getting the fluids in like a more delayed fashion than what would be like ideal, couldn't that contribute to their increased mortality as well as to your like prior point? I don't know if they discussed that.
So I can't remember exactly, but since it was a randomized control trial, and it was actually a really well done study. Basically, as soon as the child was presented to the emergency department and enrolled, they had all of their everything that they needed in a tackle box. So the treating physician then went to the tackle box, and in there were the blood culture bottles, the antibiotics, the randomized fluid that they would be getting. And so it was there, and it was basically as like quick and streamlined as it could have been. But I do want to unpack your question a little bit more, because I think that there's something important. It's another point in it that's really important. When we talk about delayed care or there's delayed presentation. So how long does it take you to get to the hospital? And then once you're at the hospital, how long does it take you to get fluid and antibiotics? And those two things are different. And in terms of delayed presentation, that's a lot harder to measure. And for all the reasons that we mentioned earlier on, in terms of like health infrastructure, referral capacity, transportation challenges, I do think that the children in that study are presenting later than, say, our patient population at Mission Bay. So they're at a different kind of point in their sepsis arc, presenting later. That being said, once they got to the hospital, I do think that in Kath's study, they got pretty quick treatment that would be consistent with like the current sepsis bundle recommendations. But I think it's an important distinction between how long does it take you to get to the hospital, and then once you're in the hospital, how long does it take you to get the treatment?
Thank you.
Good question. So AHA actually also updated their guidelines. I don't know if you had noticed this, but in 2015, I know they have a 2020 version, but 2015 was the first time that they kind of started hedging or adding some language that is a little bit, I guess, more flexible. So they admit or want to reinforce that rapid and early IV administration of isotonic fluids is the cornerstone of therapy for septic shock, but specifically in settings with limited access to critical care resources, we should use extreme caution. And then this idea of individualized treatment and frequent clinical reassessment. And so I think that piece is really important, the clinical reassessment, of course, acknowledging that in itself might be resource intensive. And then the Surviving Sepsis campaign, these are the pediatric guidelines, actually do make the distinction, which I appreciate, between, you can see once you've identified that a child has septic shock, you can either go right or left depending on whether there's intensive care or not. So it's kind of exactly what Asya was saying. It's like, well, which setting am I in? Am I going to do my aggressive fluid resuscitation because I have full backup? Or am I going to wait until the child is hypotensive? And then is that the patient population that's sick enough that I'm going to reserve fluid resuscitation for? I will say that there's low quality of evidence for both. So just that caveat that we're still extrapolating a lot of data from adult studies. So that was a lot of data and kind of rehashing it all. But let's just summarize kind of what we know and what we don't know. So we know from the study that Matt did in Uganda that it's definitely still a challenge to identify sepsis and those who are at risk of death, and that the current pediatric sepsis definition is really far too sensitive and it's not specific enough for what we would hope it would be. We know from the South African study that delays are common and that really impacts patient outcomes. And we know that from the survey that even when patients reach care, that the lack of resources prevents the ability to implement the evidence-based guidelines. And finally, even once patients get to care and if the resources are available, we actually still don't know what the optimal therapy is, specifically around fluid resuscitation. There's very little debate about antibiotics. The only outstanding question is, does it have to be within 1 hour, or does the cliff really start at 3 hours? But antibiotics are a yes. The fluid resuscitation is still very much being debated and worked out. So the way that I kind of put all of this together is say, okay, we don't know a lot, but I think that the optimal management of sepsis is really dependent on the setting that you're in and then the patient population. And so it's going to need to be tailored to those two specific things. We're not going to be able to generate data in the United States and plop it down in Uganda or Kenya and expect that it's going to work the same. We really need to have region-specific data and then develop protocols that are context and patient population specific. And that's really been the thrust of the work that I've done. I'll go through this relatively quickly and just gloss over it, just to give you an idea of how I've kind of developed my career and how it's research focused. How I started with these questions based on fluid resuscitation and sepsis management in a resource limited setting, and how I've turned that into a clinical research academic career. And I'm happy to talk more about this offline. So this is just like a really high level overview. So the first study I want to tell you about really aimed to identify children with sepsis who are at high risk for mortality. So remember, we're not very good at that. So this was a 1-year cohort study, prospective cohort study in children 28 to 14 years. We screened almost 10,000 children and enrolled over 2,000. It's a mixed method study. I'll just tell you about the quantitative pieces right now. And we, we used SIRS criteria or clinical, if I can get it to go, clinical SIRS criteria to define sepsis. And what that means is we took this SIRS criteria, but the components that were laboratory based, we replaced them with a clinical symptom or sign. So for example, we added hypoxia, the need for additional oxygen or positive pressure, and then took away the lab criteria for the white blood cell count and added this ill appearing or distress or altered mental status component. And our primary outcome was mortality, and we actually identified 11% in hospital mortality with relatively good follow-up. We did lose some kids, unfortunately, to follow-up. So I thought, wouldn't it be great if we could identify the children at highest risk of death at the time that they present? Like, that's really what we want to be able to do. Resources are scarce. How do we prioritize what we have for the kids that are sickest and improve their outcomes? And it turns out that there are clinical scores that are designed and validated for resource constrained settings, including in malaria endemic regions. And these were the 3 that we tested, including, I don't know if you've heard of the Blantyre coma scale, but it's basically a scale for mental status developed and validated for malaria endemic regions. Specifically, it was for cerebral malaria, but it's been validated in other settings as well. And it's pretty simple to follow, which is one of the advantages of it. But you can see these other 3 scores vary in terms of the number as well as the complexity of the signs. The LOD score is the easiest with just 3. Is a patient prostrate? So that has to do with their overall gestalt of whether they're able to sit, stand, or feed at an age appropriate level, and then in increasing kind of complexity going down. So I looked at those scores and I tested them. I looked at the area under the receiver operating characteristics. So remember that an ROC of like 0.5 is as good as like flipping a coin. So it doesn't help you predict anything. And here we're predicting mortality. And so the closer you get to 100, which is unattainable, but the closer you get to 100, the better you are at predicting the outcome of your of interest, which is again mortality. So you can see that overall, none of these scores actually did very well in this sepsis cohort. The best one was the 6th score at 0.78, which is okay, but it does leave some room for improvement. So I thought, I think that this can actually be improved, and we're working right now to combine clinical signs as well as point of care tests to see if we can improve on this overall prediction. The next thing I was interested in was how often do we actually know what the etiology of sepsis is in these patients? And so we looked at the kind of different tests that you can do to identify the source of sepsis. So for example, is there a focal opacity on chest x-ray to identify pneumonia? And so of the kids who were tested, you could see that 31% had pneumonia. Same thing for malaria, using a rapid diagnostic test or smear, about 7% were positive. And then looking for sources of severe bacterial infection, bacteremia, UTI, and meningitis, actually pretty low proportion of tested patients were positive. So when you pull it all together, only 10% of kids had a source identified from any one of those means, and only 22% had any microbial culture performed. And I think most of us know that the mantra is you get cultures and then you give antibiotics, and you do that in like 1-2, and it's like almost an automatic reflex, right? So it's kind of astounding that this is a sepsis cohort and only 22% are getting even one type of culture, let alone the battery of tests. And so it means that it makes it really hard to identify the source. And part of that's because of diagnostics, but also because they're just not being performed when they are available. And I will tell you that about 40% of the kids received antibiotics before they got to Mohimbili, which means that even if there were cultures done, oftentimes they would be sterile. So it's an insensitive test. It just leaves this big question mark as to what the cause of sepsis is in this population. So I want to shift gears a little bit. We're going to talk about biomarkers. And
Teresa, can I pause you for a second on the diagnosis question?
Yeah.
I'm just wondering, because I know that you did this probably before the PhDc study that came out, also, I think from, I don't remember, Tanzania, maybe. And I'm wondering if you're able to look at your data retrospectively using the PhDc score and see if that actually performs better than some of those things that you did look at.
I didn't. Can you send me the reference? Because we still have all the data. We can crunch numbers. And one of the things that we're going to do is compare our tool, our bedside prediction tool, to the existing scores. So hopefully we can improve upon it. But if we don't, then we should use the one that works the best. Awesome. Thanks so much. Yeah, I can look at that and see if we have some of our limitation was missing data, to be honest, and especially if a score relies on lab data, we had that inconsistently. But yeah, I'll take a look. Thank you. So then I think that this has come up in a few other talks over the last couple of weeks as well. Like the holy grail would be if we had, one biomarker that told us if a child had sepsis or not. And Annika really talked about this as well yesterday. And we use biomarkers as part of our clinical decision-making. We use our CRPs, procalcitonin now as well. We try to determine if a kid is severely ill or has a severe bacterial infection. But those tools are often not available in a resource-constrained setting. And I will say it's even more complicated by the fact that in malaria endemic regions, you have this overlap, right? So a kid could have sepsis or malaria and clinically look very similar, right? Like tachycardic, febrile, they could have hepatosplenomegaly. And not to mention that malaria can actually cause sepsis. So how do you, with only your clinical exam, try to distinguish between these two, which have different treatments? So this was a cohort study out of Malawi, and it was a healthier cohort, I will say, because they presented to the community health center, and it was kids under 5. They had uncomplicated. They presented with fever, and then we had a control group, which I won't tell you about. And then we basically wanted those that just had uncomplicated malaria and a fever. And then with the kids who had sera available, we were able to apply the SIRS criteria and then classify them as having sepsis or not. And then within the groups with sepsis and without, we further categorize those to be with malaria or not. And so we're really trying to drill down into those 4 clinically distinct categories. So do you have sepsis? Yes or no. Do you have malaria? Yes or no. Do you have sepsis due to malaria, or at least the coexistence of the two? And then we measured serum pro and anti-inflammatory biomarkers from presentation. And I'm only going to show you a brief snapshot of it, but basically the high-level summary is that there were significant differences across the illness groups. And so what you can see here on the right is that we have malarial fever, non-malarial fever, malarial sepsis, and non-malarial sepsis, which are those 4 clinically distinct categories that we're interested in. And what we want to see is that there's different peaks of the biomarkers so that we can say, aha, like this is always elevated in non-malarial sepsis. And what we found actually was that, and again, you only have one panel here to look at, but take my word for it that malarial fever and malarial sepsis had basically the same profile. So couldn't tell the difference between the two. And this IL-1 beta was interesting in that it was different between the non-malarial sepsis and non-malarial fever. So that was one distinguishing characteristic. But overall, it looked like the differences that we were observing were actually due to malaria and not sepsis. And so we weren't able to identify a sepsis-specific biomarker profile, but we took a couple of biomarkers of interest and wanted to look specifically at their predictive ability. And this is predicting sepsis, so not mortality in this group. And again, the area under the CV operating characteristic of 0.5, which is that straight line, is as good as a coin toss. And so if you look at ANG2, it doesn't perform very well as a single marker. IL-1 beta by itself has a area under the receiver operating characteristic of 0.71. And if you combine that with ANG2, as well as a marker for malnutrition, weight for age, and malaria, it gets a little bit better at 0.77. But remember what I said, that's about where the 6 score was. So it leaves definitely room for improvement. And I wish that it was higher and more predictive. And then I'm going to breeze through this and just say that we've been using next generation sequencing, which is the sequencing platform that identifies any fragments of RNA and DNA of pathogens in any biospecimen for pathogen identification. So it's highly sensitive. We did this in Uganda, and we were able to identify actually primarily viral infections in a cohort of febrile children. So I'm going to skip this part and just say that it was an incredibly sensitive technique. And overall, we found a lot of viral infections in this population. And so trying to pull all of this together, I think the work I've done in Tanzania, I think that the current approaches to determining high-risk children are inadequate, and that determining what the primary infection is challenging. From Malawi, I think that biomarkers could improve the diagnosis of sepsis, but we've yet to find that like single biomarker that is ever elusive, but we're all striving to find that could help us identify sepsis, especially in malaria endemic regions, which makes it more challenging. And then I think that there's great power and utility in using the sequencing to be able to determine the pathogen, especially in settings where microbial culture is unreliable or not available. So that leads me to the next steps, which is what my current project is, and that's using clinical data and then the next generation sequencing for etiology of sepsis or severe febrile illness, and then using point of care biomarkers to determine or predict risk in children, and then develop a treatment algorithm specifically for children in East Africa. That's the current body of work. And I think it's worth mentioning the big picture because there is definitely a lot of cool science in here, but the important piece of it is that we're leveraging and using the science that's available at UCSF, but with the purpose of developing a sustainable, relevant, and feasible intervention for resource-constrained setting, and that's population-specific. So in the last couple of minutes, I do want to make sure if you're interested, you might want to get your screenshots tool ready if any of this is interesting to you. For those who are in training and thinking about additional critical care and or global health experience, we've just launched a new pediatric critical care medicine global health program here at UCSF. And that's if you're interested in academic career in critical care and global health. So it's 4 years. So it's the normal critical care fellowship is 3 years. So this is an additional year, which is dedicated to research. You get to do a global health fellowship project that's longitudinal throughout your fellowship. You get mentorship in both fields and the opportunity to get the master's in global health sciences here at UCSF. And then that extra year of research is really, for those who've done research in an international setting, that extra time is really beneficial. And then other fun things, if you want to learn more about sepsis or fluid resuscitation, or just know what current events are, World Sepsis Day is coming up. It comes up every year, September 13th, and there's a lot of events and hype and advertising that goes into that. And I will say that WHO has just recently, they're restarting their guidelines process. That usually takes a couple of years, so don't hold your breath, but they are trying to develop sepsis guidelines that will be applicable across settings. And then WIFPICS, the Surviving Sepsis Campaign, are trying to revise the pediatric sepsis definition so we have something better than the SIRS criteria. And then last time I checked, there were about 68 active pediatric sepsis trials that were registered and about 5 that were looking at fluid type and volume during resuscitation. So it's an active area of research and a growing volume of literature. This is the screenshot page. So if you're interested, there are different ways to get involved, whether you're interested in research, advocacy. AAP's got a great section, the CUGH as well as WIFPICS. And so here are some good resources and things to check out. And then specifically to build onto this topic, at the end of September, there will be a virtual conference that's hosted by the African Sepsis Alliance that is all about rethinking sepsis in resource-constrained settings. And it's free to register. So if you're interested, I didn't include the link, but you can Google this, and I think it will be a really interesting talk or series of talks over the 2 days. So that's it. And I have like 2 seconds to spare. So thank you all for your attention. I realized that was quite a lot to go through. So if there's any questions, I'm happy to take them offline as well. Here's my email in the chat if you just want to copy it. And then for the residents, of course, I'll see you many times. We'll have chances to talk. But any last minute questions, burning advice, other things? I saw some really good studies and articles and references put into the chat too. So I'll check those out. Really appreciate that. Okay. Well, thanks everyone for your time. Tiffany, would you be able to put the eval link in the chat for me really quick? If you have a moment, it's literally 2 questions, but I do take the feedback every year and revise the talk based on what you say. So let me know what worked and what didn't. And we have one more session today that will start at 10:30. Thanks all for logging in. Really appreciate your time and your engagement. It's never easy over Zoom. All right, take care. Bye.